I'm Kim Gerhart, and my research proposal is on childhood adversity link in professional boundary violations. Counselors and medical professionals need to be aware of potential boundary violations in order to provide safe, ethical care for their patients and clients. And according to Fasasi and Alawu, boundary crossings involve deviation from commonly accepted practice that may or may not cause harm, whereas boundary violations depart from accepted practice and place clients and therapy at risk of harm. Out of my desire to not harm clients, I wanted to find out what risk factors may be associated with those who commit boundary violations. According to Evan et al. 2013, a frequency analysis revealed that licensed graduates that did not attend K-PREP accredited programs were reported for ethical misconduct significantly more than those who do attend those programs, suggesting that they do a better job educating about ethical practice. Merriman in 2015 also suggested receiving early education about compassion fatigue and regular supervision that can aid in prevention of boundary crossings. I decided to focus in on a recent study by McDonald et al. In 2015. They assessed 100 medical professionals participating in a remedial program for boundary violations. This study suggested support for the potential link between childhood adversity and boundary violations, partly due to insecure attachment and early maladaptive beliefs. This study suggested some defensive responses and self-report bias regarding secure attachment that produced overestimation of correlations among variables. According to Roback et al. 2007, referred population samples often generate self-reports with a positive response bias. So McDonald et al.'s study suggested that further study be done to assess if this is true, so I chose to fill this gap in the research by including reports by their significant others, utilizing the dyadic adjustment scale. I hypothesized that the boundary violators, the participants in the McDonald 2015 study, would demonstrate positive self-report bias, overestimating their attachment style, with DAS mean scores being greater than the mean scores of their significant others. The null hypothesis is the participants in the study did not demonstrate self-report bias, overestimating their attachment style. With a DAS mean score of the boundary violator participants would be less than or equal to the mean scores of their significant others. So the participants in this study included a total of 200 with two groups. Group 1 includes the 100 participants from McDonald's boundary violation study, and Group 2 included 100 of their significant others. The majority of Group 1 participants were middle-aged male physicians who represented a wide range of specialties, and the majority of Group 2 participants were middle-aged females that were not physicians. As a follow-up to their remediation program participation, these individuals were notified by mail and email requesting they complete the dyadic adjustment scale in an undisturbed environment and then submit their results within 2 weeks. The DAS is an empirically supported self-report questionnaire that measures relationship adjustment in specifically 5 areas that include troublesome relationship differences, interpersonal tensions, relationship satisfaction, relationship cohesion, and consensus on relationship functioning. There are over 1,000 published studies supporting the use of the DAS, which is a valid and reliable assessment. a reliability score of 0.915 with a 95% confidence interval ranging from 0.906 to 0.922, with an acceptable cutoff value being 0.70. So this was proven to be valid and reliable. The DAS is also available on public domain and includes 32 questions that can be completed in 5 to 10 minutes, so it's easy to take. And it includes questions such as, do you confide in your mate? And how often do you laugh together? Are some examples. A causal comparative ex post factor design was chosen since this study involves two pre-existing groups that can be compared to discover possible variations in measurement of attachment of these participants. No manipulation was required, random assignment was not suggested, and two groups were compared to assess their differences. The dependent variable is self-reporting bias of attachment, and the independent variables are the scores of both groups of the DES mean scores. If group 1's mean score is significantly higher than group 2, which is the significant other's mean score, then it will support the hypothesis that self-report bias existed in McDonald et al. 2015 study. So after concluding this study, the results of this study, using an independent sample groups t-test, the results of the study supported the alternative hypothesis with a group 1 mean score of 97.24 and a standard deviation of 15.48, and group 2's mean score was less, which was 87.23, and a standard deviation of 10.75. The results are statistically significant, with t equaling 5.31, which falls beyond the critical value of 1.65 at the 0.05 alpha level. So the null hypothesis is rejected and the alternative hypothesis is supported. According to these statistics, the boundary violation group 1 demonstrated non-distress in their relationship adjustment, whereas the significant others group 2 demonstrated distress in their relationship adjustment, supporting positive self-report bias in group 1. The results of this study also suggest that individuals referred for remediation programs for boundary violations tend to answer with positive self-report bias regarding their relationship adjustment, and incorporating reports from their significant others can give a more balanced perspective. The results of this study can also alert facilitators of remediation programs for healthcare professionals and counselors to be aware of participants' potential self-report bias and include an educational piece to increase self-awareness. The limitations of this study involve a self-report assessment relying on the participants' level of self-awareness with possible inflated self-assessment and no true facts. The limitations of this design include no random selection, and without random assignment, results are limited to the study and restrict generalization to the public as a means to control external validity. Despite these limitations, though, the strength of this study includes the use of the DAS, which is an empirically supported instrument that measures relationship adjustment. A recommendation for future research would be to see if there is a correlation with boundary violations and distress in their primary relationship. This could be done by comparing results of DAS scores between two groups of couples, group 1 being those who have experienced a boundary violation, and group 2 with those that do not have boundary violations, couples that have not experienced boundary violations, to see if there is a significant difference between each group's levels of relationship adjustment. To conclude, these findings can aid facilitators as they work with boundary violations, violators in remediation, And they can also guide the development of preventative interventions for healthcare and counseling professionals by including self-awareness education. Thank you.